Hello, thank you for your kind introduction. So maybe Carlo, my talk is because like my work. So maybe you're starting doing the colonoscopy by yourself. So it's not you will not have the problem with it at all. So I don't know about the MDT because my patient is finished at the endoscopy. So yeah. So I would like to thank you, the organizing committee, to give me the opportunity to share my experience today. I'm Supakij Khomvilai from Colorectal Hospital. It's my hospital in the center of Bangkok. I'm a colorectal surgeon. My main work is the colonoscopy, not the surgery at all. But endoscopy is like one kind of the surgery. Colorectal cancer is increasing all around the world, including the Thailand, right? So we, as a surgeon, we found a patient like this. When the patient gets the symptom, it's too late for the endoscopic resection, right? So we have to do the surgery, emergency, sometimes a colostomy, have the problem. But luckily, the colorectal cancer is starting from the adenoma. So the screening is the way to go. Starting doing the screening all around the world. NCCN guideline recommend the colonoscopy is the first choice, but you can do the others because the number is way too much. And then from the study, you can save the life almost 50% if you do the screening. So that's why we starting our surgical endoscopy in our hospital in the 2009, 15 years ago. At that time, this is my endoscopy, starting from one case a day. It's like the old generation of the endoscopy, because we know that when we do the screening, we have found more of the early state of the cancer, stage 1, and easy to combat, and sometimes it's the complete remission. So the question is, like my talk, how far we can go for the endoscopic resection. Of course, if it's the benign, so we can do the endoscopic resection, right? So now how about the cancer? Yes, we can do the cancer if the cancer is the early cancer. But if the cancer is the invasive cancer, you should do the surgery to remove the lymph node. So how different between the early and invasive cancer? The malignant polyp is not just the invasive cancer. We have the intramucosal cancer and a superficial submucosal cancer and deep submucosal cancer. So if the cancer is the invade through the musculature mucosa more than 1 millimeter, we consider it that a deep submucosal cancer because it has the chance to go to the lymph node. And without lymphovascular invasion, polydifferentiation, endoscopic treatment can achieve. And we confirm it by our study in our patient in Chulalongkorn Hospital. The T1 colorectal cancer have lymph node metastasis around 10%. That means 9 from 10 is the unnecessary surgery. So we confirm that the same thing is from the study from the other all around the world. So the JSCCR guideline recommend that endoscopic treatment for T1 colorectal cancer is okay if it's no lymph node, no polydifferentiation, the depth is less than 1,000 micron without lymphovascular invasion and the budding. And the recurrence is very low when you can do the en-bloc resection. So for the cancer, you can do the endoscopic treatment. Of course, if they have no chance for lymph node metastasis. But if it contains a chance for the lymph node metastasis, you should do en-bloc surgery as an oncologic resection. So how could we know that the lesion that we found, which one we should do? So we use we call the IEE, image enhanced endoscopy, to see the lesion and what is it. So it looks like this. When we found the polyp, use the differentiation using the NBI or the dye, and then you choose the treatment for the patient. A lot of the procedure that we can do, I show it today. But if you cannot do it, just take the photo. Don't do biopsy or the tattooing, because sometimes it's difficult to do endoscopic treatment. And we use the NBI, narrowband imaging. Everybody know about it. It's the image enhanced technology. And then we use the classification to justify what is the polyp look alike. And with the new generation of the endoscopy nowadays, you can scan QR to see in my YouTube channel. And then I show you today about the technology that we use. And this is our endoscopy right now. It's from the 2009. And this is all the technology that we have right now. Okay? Yeah, maybe this one will wake you up after the afternoon session is very sleepy. So currently, you would find a polypoid lesion like in the above, but actually we can see the non-polypoid lesion in the below. with the new generation of the endoscopy. Oh, image is okay. How about this one? Can you see the lesion? Yeah, it's over here. Right. So this is the new generation of the endoscopy that we found the lesion. And we can compare on the left side is the white light. On the right side, we're using the new technology called the TXI or texture and color enhancement. So we can detect the lesion is more easily compared to the previous generation of the endoscopy. And we confirm with the NBI, so this is the polyp that we found. So what is the TXI? TXI is like the enhancing of the color and then the texture. So we can see it look like the contrast of the image is more contrast. So you can detect the lesion is easily. Normally I use the TXI mode number 2 instead of the white light during withdrawal to detect the lesion. And this is what it looks like when we do the exactly endoscopy. And switch off the TXI. And when you switch on like this, you can see that this is the lesion and detect it easily. Confirm with the NBI, this is the adenoma, the nice type 2. In this case, it's a little bit wide, and then the size is more than 1 centimeter. So we can do the EMR, but actually I'm doing the pre-cutting EMR to secure the margin of the lesion. So using the dual knife and do the circumferential cutting, mucosectomy, and then pressing the snare to get the negative margin like this. And this is of the cutting. And we close the lesion by using the endoscopic clip. Like this. Okay. So this is what we're doing in every day. And then we're using the NBI to see that what is the lesion look like. On the left side is nice type 2, is the tubular adenoma. On the right side, it's invasive cancer. So with the NBI, you can differentiate the lesion is easily. And this new generation, like this is the white light. And look at the detail with the 4K image of the NBI right now. And this is the adenoma. And of course, this is another one. It looks like the sharper of the 4K image. And this is adenoma. So we can accurate diagnosis by using the new generation of the system right now. And also for the exercise-related lesion, you can see the detail of the open pit type 2 on the right side, and you can confirm this is the exercise-related lesion. So I confirm it again. If there are some part of the cancer, you have to resect it en bloc. Okay? And this is my endoscopy right now compared to the 15 years ago. So we have everything that have in the world. And then, yeah, we're using the scope guides, using the new generation, using the CO2. And also I'm doing endoscopy by sitting. Yeah, so we're fine. Yeah, 1 hour, 2 hours, yeah, easy. Chill. And then now we have the AI. And then the AI help us to detect more of the lesion. So yeah, it's for if you look at the literature, it's a lot of the study of the AI, right? And for the expert, they say that it may not help. Yeah, it's not help. But yeah, if you do 1 or 2 cases, in my case, it's 15 to 20 cases a day. In the case of the 15, maybe it's a little bit fatigue or something. So yeah, I can help. How about this one? What do you think? Is it benign or the cancer? So yeah, with the NBI and with the EDOF function, it's like the near focus, and then you can see the whole image within one frame. And with the detail closely, you can say that this is a cancer, but it's not the invasive cancer. It's the early cancer. That's what we say. And then this is the genet type 2B, and then this is the early cancer. And I choose to do the pre-cut EMR for this lesion, and pathologic result come back as a shallow invasive cancer. And then this is 6-month follow-up. Okay. And then how about this one? The lesion very flat on the hepatic flexor, so we can detect it and spray out the indicocamin to highlight the margin of the lesion. With the NBI, you can say that this is just a adenoma. It's not the cancer at all. So I do the ESD for this kind of the lesion. This is the standard ESD procedure. So usually using the cap because the endoscopy, we have only one hand. So use the cap to open and go into the submucosal layer that we're doing. dissection. So like the two hand together with the traction from the gravity. So yeah, this usually start with the incision, go to the submucosal layer, and use the cap to get inside the submucosal layer, which is the bluish line that we created by injection of the glycerol adrenaline to the submucosal layer, and using the knife, actually is the needle, to cutting into the submucosal layer like this. So the diagnosis before the operation is very important. You have to properly select the case to do the endoscopic resection. So you can select this. This is almost a finish. Okay, and after we reach the oral side of the lesion, so we doing the cutting in the oral side, and this is the finish. Like this. So this is after the resection, securely removed by the endoscopy. And the pathologic study is the tubular adenoma with high-grade dysplasia. So after the follow-up, 1.5 years, everything is fine. How about the circumferential lesion? Bigger size with the NBI. It didn't show any invasive lesion or any part of them. So securely dissected by the endoscopic resection. The same technique, right? This, look at on the right side, this is a whole specimen that we remove from the endoscopy alone. And the pathologics come back, tubular villus adenoma, high-grade dysplasia. Okay? And how about the lesion that's close to the anal margin? Of course, you can do the transanal excision. And how about the ESD? Yes, we can do it. So this is after the resection, like this, and it's the tubular villus adenoma, again with the high-grade dysplasia. And also this is after the 8-month follow-up, everything is fine. So how about the more challenging lesion, IC valve? So this lesion is involved into the IC valve. So from the NVI, it's just the adenoma, I believe. So this is a little bit challenging because of the first is on the right side. Second is in the one part of the IC valve and include inside the terminal island. So we're starting the injection and the cutting to secure the margin include inside the IC valve. So we do the cutting on the oral side first, like this. But the contouring of the scope is a little bit difficult, especially you go in the IC valve like this. So not easy one, but yeah, we can do it. So like this. After getting the margin, so we start this section from the anal side, like this. You can see it's like the slow movement because of it's very difficult to control the scope during the ESD procedure. But after you get into the submucosal layer, so the same technique that we do, like this, and then on the anal side, another part, and this is after the resection, like this. Okay. And in this case, after the ESD, usually close the lesion. In this case, I'm using the traction clip, the traction device, like this, to make sure that I get on the oral side of the lesion to close the lesion completely. And this is after the close all of the resected part. So this is a specimen. And then the pathology come back, tubular adenoma, high-grade dysplasia. Yeah, that we can do. And of course, this is another challenging into the appendiceal orifice. You look on the right side, that the appendiceal orifice, the lesion did not go into the appendix, but just a part of them. So securely cut by the ESD procedure, like this. And then it's the sessile lesion, no dysplasia. The patient is fine. How about this one? Recurrence after the several times of the polypectomy. In this case, a lot of the fibrosis with the ESD, we can do the same thing, but deep down to intramuscular layer, intermuscular layer. We call it the endoscopic intermuscular dissection. It's the same technique with the ESD, but deep down into the muscle. So because of the clear image of the system right now, so you can identify the muscular layer, and you cut only one part of the muscular layer like this. The same technique with the ESD. See? Is yeah. I hope this one will wake you up after the afternoon session. So like the appetites, the dessert, like this. This is after the resection. So just one part of the muscle that was resected. Okay, and this is the specimen. And how about this one, the invasive cancer? So this case is not suitable for the ESD, but the patient insists that don't want to do the surgery. Okay, how about the whole resection, the whole layer resection? But we can use right now we use the innovative device, the endoscopic needle holder, like the laparoscopic surgery. So we now can suture the lesion, the wall of the rectal that we resected by using the needle and V-lock to close the lesion. That is what's the dream come to right now. We can do the endoscopic resection and close it by doing suturing, real suturing, not the device. It's 10 times cheaper than the endoscopic device that you already know. It's 10 times cheaper, but it's not easy. But yeah, we can do it. Sorry, this is just my first case, and then a little bit not so good, but yeah, we can do it. Yeah. And almost finished. Yeah, this is the finish, and then yes, because of the first case, so I clip a lot. Yeah, to make sure that it's okay. Yeah, that is the new one that we're doing. So, yeah, this is all of the endoscopic resection that what we can do. So, if you're interested in the endoscopy, just follow my YouTube channel. Yeah, Endoscopy 101, we have everything. And then also from my colleague, Dr. Ben, endoscopy. And recently, we have collab with the Ohata Endosalon, the Ken Ohata from Japan. He's very famous endoscopist. We collab the channel. So I have the connection to the YouTube channel. So in conclusion, the nowadays technology of the colonoscopy, we can get the accurate characterization of the lesion by detailed observation, remove it proper and severe procedure, including oncologic resection for early colorectal cancer. The cancer can be preventable. Screening, reduce the incidence and mortality. So find the polyp, cut it out, save life. Thank you.